Thank you so much, everyone, for having me present today. I'm Amanda Lavigne. I am a substance use clinical nurse specialist with Interior Health. So I just want to start off my presentation in a good way by acknowledging that I am privileged and grateful to influence work that spans across the beautiful lands of the traditional, ancestral, and stolen territories of Interior Health, which consists of 7 First Nations regions, which are the Kakal-Dene, the Ktunaxa, the Inklakutma, the Secwepemc, the Statliam, the Silks, and the Chilcotin First Nations peoples. And it's with humility that we in Interior Health continue to strengthen our relationships with First Nations, Métis, and Inuit people. So I'll be going over the nurse prescribing overall in BC, and then just a bit of where we're at in terms of scope, and then how RN and RPN prescribing has been implemented here in the Interior Health region, a bit of data, and then what our next steps are for expansion. Certainly, I think we previously had a presentation by some fellow CNSs in Vancouver and at this meeting, and they did a fantastic job of really outlining the devastating impacts that the toxic drug crisis has had on our province. So just I'm not going to kind of repeat all of the information that they have provided, but I can certainly provide links if anybody's interested. But just emphasizing that toxic drug deaths have and continue to be at their highest in our province and devastating people who are using substances. And also noting that 70% of those who are dying were aged 30 to 59. 79% of deaths are male, and that 38% of descendants were at least 50 years old. So driven by this change to the toxic drug supply, Dr. Bonnie Henry was certainly motivated to make some changes, and she created a provincial health order. So this was issued back in September of 2020, and this allowed for RNs and RPNs to be part of the workforce and able to prescribe first-line treatment for opioid use disorder. And she stated that she's of the opinion that there are insufficient human health resources available to meet the needs of people who use drugs, as well as she emphasized that the worsening situation of overdose deaths are arising based on the impacts of COVID-19, and there being 2 dual public health emergencies, and noted that she felt that registered nurses and registered psychiatric nurses possessed additional education and preparation and experience to be able to support in this health crisis. So her order was quite vague, and it created an interesting discussion when it came out. So the order was that RNs and RPNs could order and interpret diagnostic tests, make diagnosis of a problem substance use condition or substance use disorder, could prescribe specific drugs, including controlled substances, and refer persons with a problem substance use condition to primary care. So without kind of additional context, this order created a lot of discussion amongst prescriber communities as to what the role of nurses would be in addiction treatment. But what it really did was launch the collaboration between the governing bodies to create a foundation for nurse prescribing. So as we know, there are different standards and governing structures that outline a nursing practice. So we have Dr. Bonnie Henry's PHO order. This then prompts the college to respond to that with standards, limits, and conditions. And those standards, limits, and conditions were also dependent on BC Centre on Substance Use developing education that they endorsed as being competent and safe to provide this intervention. And then, of course, as organizations, and many of some of us are on the line here who are implementation leads for this work, really had to scramble and make sure that our policies were outlining and underlying this change, and really making sure that we had the guidance in place. And then, of course, individual nurses had to complete the training, their preceptorship, and be really clear about what their competency was. So one of the things that I think was really interesting when nurse prescribing first came out was, and I think nurse practitioners, if there's any nurse practitioners on the line, can kind of remember, and nurse practitioners have been rolled out across North America in different ways, and some have had more autonomous scope than others. And there was an assumption that as nurse prescribers, they required oversight or a co-signing by physicians. And that's actually not the case. RN and RPN prescribing is actually an autonomous scope. So they are able to write an order as long as they are meeting the standards, limits, and conditions of their college and have that required provincial training. So I always encourage people to go to the BCCNM website. They have the limits and conditions specific for prescribing of opioid use disorder laid out really nicely. And it's something that I think a lot of people have questions about with regards to their autonomy. So I always direct people back to the BCCNM site. But there are differences in the training. So there is what's called POTS-P is how we usually refer to it as, but it's the Provincial Opioid Agonist Treatment Training. And the difference, so currently nurse practitioners and physicians, this is a provincial-wide training that BCCSU manages and organizes, and they have made it free. Which historically, prior to the declaration of the overdose crisis, it was not free. And so BCCSU has taken on managing this training, and it is free to nurse practitioners and physicians. They manage a large list of preceptors that are available province-wide. And it consists of online courses and about 16 hours of clinical preceptorship time with a BCCSU endorsed preceptor. Nurse prescribers, so there's been kind of several iterations. Those of us who were kind of the original cohort of trainees, we took the original POTS-P with additional clinical hours as well as a workbook. But how it's evolved now is that there is a separate RN, RPN, POTS-P pathway that nurses can sign up for. They do need endorsement from their clinical lead for their health authority. So someone like myself or a different clinical lead for the health authority would submit their name via a form straight to BCCSU, and that allows them to move beyond just the online portion of the training to register for a preceptorship, get the workbook, and complete the training and be certified through their college. So currently, right now, the scope of practice for RN and RPN prescribing is that they're able to initiate and prescribe buprenorphine naloxone. That's oral form only. And then with methadone and slow release oral morphine, they are allowed to provide continuation, titration, and restarts as long as the person has had an active prescription from another provider within the last 30 days. So the next phase of that is that we are looking at adding initiation to this, but currently nurse prescribers are limited and they're not able to initiate a prescription. This is certainly guided by best practice. So this is their guidance is based on the provincial BC Centre on Substance Use Opioid Use Disorder guidelines, which are currently going through a provincial review and reiteration and should be posted by the summer. And then within, in addition to the guidelines, nurse prescribers have their own decision support tools for each of these medications that allow them to consider what's within scope and what's without of scope, and how to manage, say, missed doses and things like that. So here in Interior Health, and I have permission to share some of these lovely faces, Interior Health nurses have been really excited about this initiative. We had our nurse in Vernon write the very first prescription. So super excited that today is the 2-year anniversary. So March 16th marks the 2-year anniversary of the first time that a nurse prescriber wrote a prescription in Interior Health. So coincidentally, I get to come and speak about, I've been speaking about them all day, it feels like, and they're quite excited. But At the time, we had trained 9 nurses in our health authority across 9 different communities. And then in November of 2022, the scope of nurse prescribers increased to include the additional training of SROM and methadone. And then again, our Vernon Rockstar nurse was the first nurse in the province to write a prescription for SROM and methadone. So lots of excitement. I always encourage our nurses to, take a selfie with their prescription pad in hand. This is huge for their practice and something that they just feel really excited to be a part of. So as I said, today has been a really exciting day. We did a big communication initiative across Interior Health and worked with our communications teams to highlight some of the great work that our nurses are doing. So where we're at today, there's been quite a bit of work. So Interior Health is one of kind of the largest spanning health authorities, and we're broken up by region. So our nurses have been working collaboratively and creatively with each other as they've come on board to kind of create these small teams within their regions. And then one thing that has been hugely successful with supporting nurse prescribing success in Interior Health is that alongside this initiative, we've also worked with multiple stakeholders and our physician team to create a virtual addiction medicine clinic. This is something that I think probably a lot of health authorities and services are interested in. I know FNHA has had great success in developing what their virtual, I think they refer to it as virtual doctor of the day or virtual specialized physician. And basically it allows consultation and active prescribing for a very short time to support bridging in between services. So we've seen some great success in having our nurses. So one of the things that's required by the medical health officers is to have escalation pathways in place. So these pathways require that every nurse prescriber, because of limitations in their scope, must have a clear pathway to be able to escalate care for both primary care and opioid use disorder. And some of our more rural, remote communities, nurse prescribers can be really challenged if their prescriber, for example, is only available once a week, or maybe there is all of a sudden a gap in their community for a nurse practitioner or a physician to escalate care to. So our virtual addiction medicine clinic has really been kind of that umbrella in our health authority region that allows nurse prescribers to be able to request care support for a short period of time. So things like, with nursing FTE, we have issues like vacancies in positions or vacation relief or, transitions and wait lists in between, say, emergency departments and community OAT clinics. And so between our nurse prescribers and our new virtual addiction medicine clinic, we've really, I think, completely just opened up access to OAT across our region. And it's been super exciting to see the two programs really work together. And so I just pulled our data yesterday and super excited that we've written over 2,000 prescriptions for OAT in Interior Health by an RN or an RPN nurse prescriber. One thing that I think, we really reflect on is managing, say, precipitated withdrawal. So in over 2,000 prescriptions, we've actually only had 12 incidents or events of precipitated withdrawal. For those who don't know, when you do an induction of buprenorphine naloxone, the likelihood of precipitated withdrawal can be very high if the person is not actually at a stage of withdrawal. And that's what a COWS scale is for, is to make sure that the person is in a state of withdrawal so that that partial agonist does not completely kick out their receptors and make them feel pretty awful. And so what we've, when we first started nurse prescribing, myself and our professional practice office were scrambling to get these adjunct medication guidelines in place and make sure there were all these, supports for nurses to be able to manage precipitated withdrawal. And what we were finding is that they were really spending a lot of time with clients, educating them, making sure that clients were having follow-up phone calls when they were initiating their medications. And we really didn't see a lot of events of precipitated withdrawal. So I think that's really great to see. I think it kind of speaks to the way and that nurses communicate with our clients. And I just, I really think that's a success that we've seen out of nurse prescribing. Because I know a few years ago in one of our larger OAT clinics, there were definitely some quite a few events of precipitated withdrawal with physician management. So we consider that a win. And then, of course, the medical health officer, and which we know is just kind of naturally part of holistic nursing care, is that they do so much more than just write prescriptions. So a lot of their work is spent referring people to resources, housing, harm reduction supplies, education. So when I'm talking to nurses, not only in interior health region, but I get the opportunity to talk to nurses in other health regions as well that are prescribing. They spend so much time educating clients on safer use. They refer people to treatment for STI. They link them to community resources. They're making referrals to primary care, and they're escalating to OAT providers as needed. And so where things are at in the provincial implementation, back in 2021, we started out with just Suboxone and that planning for that virtual emergency department addiction medicine support. Since then, we've really been able to expand to include quite a number of our smaller rural communities and create kind of those regional teams. We increased scope back in 2022 to include SROM and methadone. And then today we're still looking at expanding communities. And next phases as part of the provincial implementation is expanding to initiation of methadone and SROM, but also including Sublocade. So we heard from day one, and actually, I think back in 2021, the nurses were like, oh, it's great that we can prescribe buprenorphine naloxone, but please include Sublocade in this. Particularly in rural and remote communities, they see a lot of people that are working or need to work away. And so that injectable monthly dosing is really more appropriate for people who are trying to juggle jobs and keep employment, and who are just, even with carry doses, sometimes their access to pharmacy is really limited if, say, they're going away to work up north in camp or something. So they're really, really excited to see that Sublocade is part of their kind of next phase. And then, of course, the vision of the ministry is to, at some point, include safe supply. So what we hear consistently in partnership and shared care with nurse prescribers and other providers is that because the toxic drug supply is so potent, some of our OAT medications are just not holding people. People are continuing to experience withdrawal symptoms even when on Suboxone or methadone. And so that need for maybe hydromorphone PRNs, which are, technically a safe supply prescription on top of their OAT is a really common practice, unfortunately, these days. And so the nurses are, working collaboratively with other physicians and prescribers. And so I just wanted to share some of the just responses from our nurses. So we did, reach out to some of our nurses in anticipation of this anniversary. So some of our nurses have been at this from day one. So this is, 2 years of them actively writing prescriptions. They've learned a lot. And so we asked them, why is nurse prescribing important? So one of our nurses in Trail said that nurse prescribing gives us the opportunity to increase capacity of OAT clinics, as well as decrease wait times for individuals who are ready for change. It increases access points for clients to start on opioid use disorder treatment, as well as opportunities for us to follow up and meet clients where they're at. And when asked what they enjoy about being a nurse prescriber, she said, I've enjoyed the opportunity to learn individual stories, who they are, where they come from, and where they want to go. I love that I'm able to provide some of the tools that can help people along their journey with health and well-being. So from our Vernon nurse prescriber, who was actually our nurse who wrote the first prescription in the province, she said, nurse prescribing OAT allows increased access for clients and offers new and innovative ways to deliver OAT healthcare. I was able to provide OAT treatment to clients who did not have active MSP coverage, which was a barrier to accessing user pay OAT clinics. I was able to provide individualized care and significantly more clinical support and intervention than what is available in a traditional office setting. And when asked what she enjoyed about it, becoming a nurse prescriber with IH was an exciting opportunity to not only grow my professional knowledge, but to be part of a groundbreaking team of nurses forging a new path to break down barriers for an underserved group of people. As the first nurse in BC to prescribe OAT, I was able to provide a lot of education and communication to a variety of community partners, including shelters, RCMP, city cells, supportive housing, pharmacies, and hospitals. I'm proud to have been a part of the nurse prescriber rollout and feel I was able to play a huge part in restructuring how clients access OAT in Vernon. And finally, from our nurse prescriber, who happens to be part of our virtual program out of Kelowna, which not only serves some clients locally, but they actually create the bridge between emergency department referrals and nurse prescribers locally in our regional communities. And so he's really excited to be part of this initiative and said that nurse prescribing is important in providing a readily accessible option for treatment for at-risk clients in the midst of an opioid crisis. Nurse prescribing is different because service is not dependent on medical coverage and it's not dependent on regular service hours. It also offers the possibility of comprehensive and supportive follow-up care. The supportive in-the-moment care model offered by nurse prescribers provides the probability of successful treatment, initiation, and retention. And as a nurse prescriber, I enjoy assisting clients in their journey towards recovery and the pride they express in their accomplishments. I also take pride in being part of the pioneer expansion of nursing scope of practice, which has added enormous value to the provision of healthcare in BC. And just before, I just always like to share some comments from people with lived experience of receiving OAT. So we did a communication highlight in the East Kootenays, celebrating the kind of collection of providers that came together in our East Kootenay region and created kind of that regional team between nurse practitioners, nurse prescribers, and physicians. And then as part of that kind of experience, they also interviewed people who receive OAT from that virtual service. And the one that I really love sharing is that our person with lived experience, Jamie, says, I've been coming to the OAT clinic almost a year now, and it has helped me change my life. The nurse prescribers there are easy to talk to, understanding, and non-judgmental. With their help and knowledge of what medications would help my withdrawals, they helped find the right program. I'm on Sublocade program, and it has been able to get my life back to normal rather than depending on something every day to get me through. I'm able to spend time with my kids and not have to worry about appointments every day. I definitely would not have been able to beat my habit if there was no clinic like this to go to. So with that, I'll just stop sharing my screen, but happy to answer any questions if anyone has any questions about our initiative.
This is absolutely remarkable. And I can't say enough about the power of you in terms of practice building. And it certainly demonstrates also what clinical nurse specialists can do. Thank you so much, Amanda.
Thank you so much for having me. It's as an RPN, so I'm a registered psychiatric nurse, and this really makes, so we're moving towards, in BC, moving towards this being a certified practice, and RPN prescribing, this will be the first certified practice that's applied to RPNs as a profession. So I hope that paves the way for opening things like RPNs being able to be part of the STI certified practice, and maybe, there's so much overlap between, what we call like street nursing and HIV positions and our overdose prevention and harm reduction teams. And so I just see such an opportunity for the RPN workforce to really leverage their scope.
Hi, thanks, Amanda. This is amazing. You talked about the risk of folks going into a type of withdrawal.
Oh, precipitated withdrawal.
Precipitated withdrawal. I knew I had the word wrong.
No problem. So what happens when you have your opioid preceptor? So if you're using an opioid, what happens if you haven't withdrawn from your opioid use? When you take buprenorphine, it has what's considered a really high affinity for the opioid receptor. And basically what it does is it comes in and just completely kicks out that opioid and will actually put you into withdrawal. Because it has a higher affinity for the receptor than other opioids. But what we're finding, which is kind of which has been challenging, is that fentanyl has a significantly high concentration, and so that it's actually creating some competition with buprenorphine for that receptor, which is why when you hear Suboxone isn't holding people, it's because fentanyl is competing for that opioid receptor, and it hasn't seemed to be as successful as a treatment as it originally was seen. So what I know in like the opioid use disorder guidelines is I think they're looking at, as opposed to saying that Suboxone is the first line treatment, they're actually just considering Suboxone, methadone, and SROM as all kind of equal opioid use disorder treatments and assessing what is appropriate. What I love that what I think our nurses add to the continuum of care for OAT is, a lot of times these nurses will wear multiple hats. So they might work part-time in an OAT clinic and part-time at an overdose prevention clinic. And what is incredible is they're now working at, the full continuum of spectrum of services. So they might see somebody at the overdose prevention site who's just there for harm reduction supplies. And then as they build that trust and that relationship, they might start coming for witnessed overdose events. And then as that relationship and trust builds, and maybe they're moving towards, changing their goals, they actually can, offer that, hey, if you come see me at this clinic, I can actually prescribe for you. And they're able to actually go out and outreach and, wear multiple hats and partner with other teams and just reach into people. Whereas other OAT models are usually that come to our OAT clinic, and if you miss your appointment, best of luck, we'll discharge you and you can re-engage when you're ready. And so that's what I'm really loving about the holistic nursing approach is their follow-up and their flexibility with being able to reach into people is, I think that's what they're most proud of. And that really is what I think what I'm truly proud of as a nursing, representing the nursing practice, is that we're really leveraging their holistic approach to OAT, and it's kind of a different way of providing that service.
So would you, if there was one thing that you would like us to take away from today, Amanda, what would that be?
That's a great question. That I think nurses can do this work differently. And, I'm currently doing my thesis on, in my Master's of Psychiatric Nursing program, my thesis is on the qualitative experience of nurses prescribing opioid agonist therapy in BC. So I've had the privilege of speaking to nurses one-to-one, not only in my own health authority, but other health authorities. And my final question to them is always, what advice would you have for nurses? And just, to build on what Elizabeth said, like they said, just do it, like reduce your fear, get rid of your fears, address your own stigma, address your own biases, and step up to this work, because this is good work and you're the right people to do it. So that would be my takeaway. And it's not my message. I'm carrying the message on from nurses who are doing this.
Thank you for watching. You have found the Clinical Nurse Specialist Association of BC's YouTube channel. Since you're here, consider subscribing. Visit our website at www.cnsabc.ca to learn more about us and consider joining us.